My name is Geraldine Strathdy, and I would like to welcome you all to this chapter in the series of Challenging Conversation panels. So for those of you that haven't joined us before, a huge welcome to this new series. And for those of you who are our regular attendees, very welcome back. This series was set up to help people working at all levels in services, the people who use services, the families of people who use services, the frontline staff, people with responsibilities from board to floor, as we say, to be able to have open, safe conversations about the issues of the way that we work in mental health today, issues that some of us find ethically quite challenging, issues of equity and equality of access and the types of treatment people get, issues of how we manage, and above all, issues of how we change systems for the better. So today I'm joined by 4 people, all of whom have in common, they're passionate about what they do, they believe in integrity, they believe in positive change, they believe in speaking out, and they're all very solution focused. The use of the Mental Health Act, the use of Section 136 is something that is very dear to my own heart. I believe fundamentally we need to challenge ourselves about it. So we're going to start today by I'm going to make 3 key points. First of all, the Mental Health Act, we've got a new reform act coming through, but the Mental Health Act we currently operate to is 1983. And Section 136, so people identified as in need of assessment or help, potentially due to mental ill health in a public place, can be assessed by police officers and brought to a place of safety. When this whole provision started way back in the 80s, those were the days when we didn't really have much in the way of community mental health services. The public weren't hugely aware, and I'd have to be honest and say not hugely supportive of community care. So is the way that we still operate this service for people in crisis, is it still appropriate? Now we're in a different century and several decades on with several different models of crisis services available. So that's one thing I'd like you all to kind of reflect on. I think the second thing, and you know it's one of my things, is are the numbers right? So we're trying to look at what happens, who is picked up on a Section 136? Who are the people? What are their ages, their genders, their ethnicity, their protected characteristics? What do we know about the social factors and their life experience that we think may be contributing to them getting to the point of crisis that they go on a Section 136? What about the clinical factors? What is it about the type of ill health people have and the treatments they're getting that mean that they also seem to be more likely to be picked up on a 136? And do we know enough about the people? And I'm just going to throw one fact at you that really gave me huge pause earlier this year. So at a London level, we had always thought, because of great work by the London Mental Health Trust Chief Execs commissioning a review every quarter of the number of people coming to the Mental Health Trust on a Section 136, we had thought that London had 2,500 people brought on a 136 a year. And then when we started asking questions and we looked at the information in the Home Office and the police data, we discovered that that was only half of the numbers. And actually the numbers for London were 5,000 a year. And my concern is always, as somebody that really believes in using information to sensibly drive changes, could you get change right if you only know what half of the issue is? So are things improving in that? And I think my final point is we know that there have been great successes in the interaction between police forces and mental health services. The Adbawali report demonstrated that people being brought, particularly people from BAME communities, into police cells was not acceptable, particularly to the BAME community, and that there were deaths and serious incidents. And we know that today in the country, the use of police cells for people with mental health crisis to be treated has reduced amazingly. Are we now ready to go another step further and actually look at, is the model of crisis services we operate, does it work for people? Is it right for our interaction with the police and communities? As you know, on this series, there's one voice that we absolutely always must hear from, and we really value hugely, and that's the voice of experts by experience. So can I introduce you to our first speaker today in the panel? Jim, would you like to just tell us a little bit about who you are and your experience on 136?
Yeah, hi, I'm Jim, and I'm here on the panel as lived experience practitioner or a expert by experience, and then I have been in the past been section 136. My story is, I think, quite similar to lots of people when I talk about it, in that I wasn't fully aware of what was going on at the time, and I think looking back on it, that is quite common with mental health crisis, is the fact that it was a crisis meant I wasn't in my own mind and I wasn't functioning. So it is slightly different in that I was actually out with my sister, who was a Met police officer, who is a Met police officer, so that she was far more probably attuned to the concept of section 136 than most people are. But I had a crisis. I wasn't acting normally, and I was outside, and I mean, probably the nicest way of putting it was that she felt that she couldn't cope with me at the time, and that she needed to get me some assistance. With discussing with her colleagues, it was basically decided that because of my size, because I'm a veteran and I was suffering with complex PTSD, and because of my military experience, that it was probably safest that I was moved to somewhere secure and safe, and that I would have probably been in danger myself, or certainly been erratic had I been left where I was. These conversations I am not aware of, because at the time I wasn't functioning, I wasn't concentrating, and certainly my concept of reality was very different. So I can remember the police turning up, but I can remember being very confused why the police were there, because I hadn't been involved in the conversation, or if I had, it hadn't registered. So that was always something that took me completely by surprise. But I think being military, I was probably far more accepting of the police and thought, well, they're here to do a job, you know, they're obviously, they're here to look after me. So I went with them compliantly. And then as far as my recall of the whole situation went, it was when I woke up in a secure unit a couple of days later. And I had bits of memory, I had bits of anger, bits of guilt, bits of frustration of what had gone on. And so for me, when I talk about my experience of section 136, my experience is very different from those around me. And that's really what stuck with me, and why I advocate so heavily now, and why I support people, is that I was in crisis, so I wasn't attached to reality. Those around me who weren't in crisis were attached to reality, and it was very shocking for them. It was very confusing for them. And something I talk about regularly to groups is that once the police arrive, you know, there are further questions that are raised in your family and your loved ones' minds. You know, is he being arrested? Is this a criminal offense? Is this going to be something that affects his career in the future? Is this, you know, and there's all these questions that are going on in the people around you, and they're not going on in your head at the time. So it was only till I got talked to my sister, called my parents. My parents came down, that I actually said to them, what was it like? And I found out that it was a very harrowing, very disturbing experience for them, particularly seeing your child being handcuffed and placed in a police van and being taken off. And then on top of that, you know, what are the legal consequences of this? Which parents, you know, as a parent myself, we think about that. You know, what's going to happen? What are the next steps? Where do we go? Unfortunately, they were very proactive, and they got me into a very good unit. And I worked with that unit for a while, going through my needs. So for me, when I talk about my personal experience of Section 136, I think confusing would be the word that I use as the patient. And it all happened, it seemed to happen very fast. I didn't seem to have a grip on what was going on. I'd sort of lost control. But for me, I think as well that we have to remember every time we're talking about this, that the families and the loved ones and the carers and the supporters are also placed in a very harrowing situation as well. And I think had I chosen to be non-compliant with the police, it would have turned into something very, very different. And I know that is the case with lots of patients who are in crisis, because they don't understand what's going on, and they don't understand the situation they're in, and they react to that. So I think I was lucky that I was compliant and that there was no force needed, you know, that I got in the van. I wasn't dragged into the van, because I can only imagine the stress and the heartbreak that would have caused for those that are trying to support you and look after you at the time. So I think for me, that's my overriding memories and concerns over having been Section 136.
I mean, Jim, that's just amazingly articulate description. Thank you so much. It kind of really conveys to us what the situation was like for you and your family at the time. We'll come back to you again, because I know that you have done work subsequently to try and improve things. So if we can come back to you again once we've heard from other panelists, that would be really useful. Thank you. Can I now come on to Mike Franklin, no stranger to this panel, wonderfully. Mike is a national lead in inclusion and diversity, but is also a kind of really has lived and breathed in many ways the issues of mental health, police interaction, and mental health services. Mike, do you want to give us your views from your very many perspectives on how should we still be thinking that it's the right thing to do what we were doing about 70 years ago?
Yeah, thank you, Geraldine, and thank you for inviting me. Jim, that was really powerful. Thank you so much for sharing that. I think the way I want to approach this really is to just talk about, you know, the perspective that I have, looking at it from a policing perspective, having worked in police oversight and having been a board member at South London and Maudsley. Geraldine, you mentioned in your opening that we worked to the 1983 Mental Health Act. And I was thinking, that's 1983, that's 2 years after the disorders in Brixton. And it's a year before the introduction of the Police and Criminal Evidence Act, which introduced independent custody visitors to police stations, tape recorded interviews, and so on. And to put it into context, I spent 10 years as a commissioner in the Police Complaints Commission, investigating deaths in custody, serious injury, police corruption, terrorism, and the like. And I had the custody lead for the IPCC, which meant that I looked at cases of use of force, detention. I had the lead for stop and search police powers, which were, you know, the way in which the police stop and search people on the streets. And I also had the lead for national policy on police negotiators. Now, police negotiators deal with things like kidnappings, sieges, hostage taking, and suicide prevention. So when you put all those things together, and then I think about my time as the chair of the Police Consultative Group in Lambeth, where we looked at policing in our community. We held local police to account. We brought to attention incidents of concern, and we campaigned for justice for people that had been harmed. Community safety was a big issue for us, but so too was public confidence in institutions. And this is the nub, I guess, for this conversation. It's not just about what we do as an organisation, as a mental health institution. It's how we work with other people, other institutions, other organisations, and it's how much we recognise those challenges that can affect our ability to do our stuff properly. So let's talk about Section 136 detentions. One of the issues for me as IPCC Commissioner with custody as my brief was I looked at not just the arrest of somebody on the streets, but how they are presented when they are taken into custody. And one of the things that used to be missed were the red warning signs around mental ill health in the course of an arrest. So the risk assessments that were given to custody sergeants when somebody was presented into custody needed to include not just the reasons for the arrest, but the full circumstances of the arrest in order to inform the risk assessment. And of course, if police officers do not think about the warning signs, then people will be arrested for criminal offences before the mental health issue is identified. And that can really make a huge difference. So I was very, very keen to make sure that practitioners, police officers who were being called to incidents, who were dealing with people on the streets, had a clear understanding of what that looks like in Lambeth, Southwark, Croydon, and Lewisham. So you're talking about areas that have many of the determinants of mental ill health. You have people that live in poverty. You have people that live with trauma. You have people that are worried about their safety. All these things impact on mental ill health. So the local context must be something that's in the minds of police officers in our communities when they're doing their jobs, to make sure that they understand that we are living in communities with many of the components that lead to mental ill health. And in fact, when I was custody lead for the IPCC, and we researched these situations, we found that the majority of deaths in custody were cases involving a combination of alcohol, drugs, or mental illness. So it's clearly the risks are there. I guess my point, Geraldine, is to make that plea that when we talk about working with other organisations, we have to understand how that may be perceived by the other people that we're working with. So people that have had negative experiences with the police will not want to go anywhere near some of this stuff because they don't have any confidence in that because of their lived experience. Now, we need to understand that. I know that lots of police officers who are committed to doing a good job, who are understanding of the environment in which they work and want to do things well. But the issue of public confidence is really, really critical. And we have to understand that not everybody's going to think, after all these years, Geraldine mentioned 1983, but many people will think that nothing much has changed since 1983. And we have to be realistic about the size of that challenge. So thank you for listening, and I hope I can contribute further to the debate.
Well, thank you so much, Mike. As always, you bring a level of insight into this that's just kind of superb. One of the things I didn't say at the beginning is that we wanted to have this part of this session organized by Charles Bell very much about the health system, and so that we're just thinking, we're not kind of sitting debating with the police. We will have another session when we will actually kind of do that and hear from the police, but we wanted to just reflect, say the kind of things that are not often said, which is, why are we still doing the same form of community outreach that we've been doing in an era when community outreach and mental health didn't even exist? So we just want to, that's what we really want to be able to challenge ourselves with that. And you mentioned the need to understand other people's perspectives. And I think for me, probably one of the big, and I've been doing this kind of thing a long time, but for me, it came as a huge shock to know that we thought in London we had 2,500 people detained under Section 136 a year. And then when we looked at the police Home Office data that had kind of not been a data set that I think people were very familiar with previously, it was 5,000. So I suppose one of the other reasons for having this session today is to just start asking the question, do we think we're any closer to really knowing the numbers, and not just the numbers, but as you say, knowing who are the people, what are their circumstances, that we could then actually start tackling and addressing some of the problems upstream. And I'm going to now ask our third panelist, Arden Tomlinson, who is the chief exec of Thalmus, is a digital innovator and entrepreneur, but whose approach to digital is that the purpose of digitalization is not just digitalization. It's about understanding the system and getting much more accurate information that enables people with responsibilities to make wise improvement decisions. Arden, tell us a bit about the work you've been doing and the new insights that I know you've gained.
Thank you, Geraldine. Hello, everybody. Yes, so my name's Arden. I'm the founder and CEO of Thalamus, and we are an organisation that has set our sights on essentially digitising the Mental Health Act, all aspects of it, and it's worth, including Section 136, and it's worth briefly touching on why we're doing that. And the reason basically is in 2016, two of my friends were sectioned, one on a Section 136 in London, and one on a Section 2 in Bristol. It sounds like he had, well, my friend who was detained on a 136 in London was a big lad from Birmingham, basically, and he had quite a rough experience getting in. He was restrained, and it was unpleasant for all involved. And what triggered me to start Thalamus is both of the families came to my dad for advice, which because my dad's a psychiatrist, and I couldn't get my head around why in a physical health crisis, car accident, an ambulance turned up and took you to hospital, but in a mental health crisis with a roughly equivalent level of risk, it was police or social services in hours or days or weeks of paper forms to get you into hospital. And once you were there, then they started to try and figure out what was wrong with you. Whereas if you have a physical health crisis, by the time you get there, if it's very serious, there's a crash team waiting for you, you know. So that was my kind of first view of digitalization. Then what I realized is we are actually trying to get, because of the nature of the Mental Health Act, it does have lots of different organizations and institutions involved. And then you run up against this challenge of trying to work out how you can support very large organizations. Metropolitan Police has 35,000 people working there. And the NHS is obviously huge, trying to get them to join up. And so our approach to digitization, first and foremost, was let's try and understand the pathway. Let's go and look, and in the nicest possible way to NHS leadership, I really want to go and look. And so we went to the 136 suites and we sat and we talked with 136 managers, we talked with police officers, and we really tried to understand the pathway as it stood. And what we uncovered actually was lots of really good areas of local practice. But what obviously we also uncovered is lots of anecdotal evidence of less good practice. And so one of the kind of key risks of digitization is that you actually just hardwire bad practice. And you end up, for whatever reason, because it's easier, because it's the path of least resistance or whatever, or because you've not listened properly, is you end up hardwiring the poor practice. And we didn't want to do that, obviously. So, I mean, at Thalamus, we have a responsible innovation framework which combines information governance, clinical safety, and lived experience into our design process. So everything that we do has to go through a lived experience check to make sure that we're not inadvertently making the pathway worse. So I suppose our take on this was, let's go and have a look. And what we found, as Geraldine's pointed out, is that half of these 136 instances weren't even being acknowledged by the kind of core data sets, really. And that was just a way of how everybody was keeping records. And even we went live across the whole net last week, and our entire program was predicated on 15 136 admissions a day. And over the last 10 days, there's been 24 a day. So even when we thought we had the right data, it's a higher number. So again, how can you start to address a problem if you don't really know how big the problem is. And I think that's the real, again, digitization is what it is, and there's a big drive to do it. Paper's bad, all the rest of it, but actually just having a digital form versus a paper form is no good unless you see what's coming out the other side of it. And now we're in a position to start looking at some relatively uncomfortable truths. 61% so far of Section 136 admissions are going straight to emergency department, which is not supposed to be what's happening. It leads to more restraint because the emergency departments are not geared up to kind of support people in that way. We know that 30% of those detained so far are black, and that's a police definition, not a self-defined definition. And that's clearly a higher percentage than the demographic. So all of this is there, and then we can start to look at, well, how long? So the average incident time of police involvement of what we're seeing so far is a little over 6 hours. That's quite a long time for police to be involved with somebody who is who's ill, you know, as opposed to a policing incident. So all of this data, and that's really what we see as our role, is we can hold a bit of a mirror up and we say, look, this is what's happening. It's not an emotional anecdote one way or the other. It's not an opinion. This is the kind of hard facts from the ground, and we hope that that can be used to inform decision making and also to test initiatives and strategies. Now this is a pan-London program. If South London or a section of South London wanted to try something, we would be able to see quite quickly in the numbers whether that was having the desired effect or not. So that's how we try and help, and we're as liberal as we can with sharing the, just to be clear, this is all metadata. So patient, obviously anything patient identifiable is kind of locked down and away. We're not in, that sounds really bad. I was about to say we're not interested in the individual. I didn't mean that. It's all about the individual. What I meant is we're not clinicians, but we can provide metadata about the pathway to people so that hopefully they can make informed decisions about how to improve it.
Thank you very much indeed, Arden. It's always great, and that's one of the great things about this series, is people who come and agree to come on speak from the heart about what motivated them and what their values are. I'll maybe come back to you in a bit to talk about, because I think you identified that you mapped a pathway, and I'll maybe come back to you about the fact that not only was there a complete misunderstanding that the police have a form 434, police have to fill in a form when they assess someone under as needing a 136, but that actually there's another part to that form, which is the whole NHS part to that form, and the discovery of part of the mapping that you did, that form was 15 years old and hadn't been amended since any changes in legislation or whatever. So maybe we can come back a bit to actually what that then showed, and the absolute inability to really understand how we could support people in the health system to do best practice with that. So my third kind of question, and I suppose my theme in chucking this at you all and the audience listening, is that have we no alternatives? So, you know, okay, this has been around a very long time, decades, but actually, is that because even though we've had a whole drive to community care, we've had different models of community mental health services, there really are no alternatives that work? And I would want to introduce our fourth panel member, who's Carly Lynch, who is, I was saying before, is bilingual. She speaks emergency medicine language and she speaks mental health specialist languages, and she has set up a really innovative service in London that we're all kind of rather proud of, and just really asking, tell us about it, Carly. Tell us about, should we have it everywhere?
Oh, thank you. That's a great introduction, and thank you to my colleagues who have spoken before me. I've been frantically kind of, you know, writing kind of thoughts that have come up. So I'm going to talk a little bit about our service, and then introduce some kind of reflections that are from me kind of personally, but also as a clinician, and building on what colleagues before me have just said. So back in 2018, which seems like such a long time ago, in the London Ambulance Service, we launched a pilot that paired a paramedic with a mental health clinician responding to 999 calls that had been coded as mental health. And it was, we were dipping our toes into kind of seeing how this would work, and we really wanted to push the parity here in the ambulance service, because obviously we were extremely good at kind of dealing with cardiac arrests or major trauma, and we really wanted to start to make sure that our mental health patients were getting the service that they needed and obviously deserved. And the reason that we paired the mental health staff with the paramedic was obviously because we know a lot of our mental health kind of callers will also have a physical health need, and on the converse, sometimes we know that a mental health symptom is actually caused by a physical health concern. So we kind of engaged stakeholders from members of the public, kind of lived experience practitioners, mental health trusts, police and wider stakeholders. And one of the absolute kind of key themes that came through and that we already kind of knew in the ambulance service was that absolutely a mental health crisis is a health and quite often a social care need as well, because I know there'd been some kind of street triage models that had been around, but we really wanted to make sure that we were looking at our patients' kind of physical and mental health needs. So the team have done an amazing job, and we now have kind of 6 cars across London. I should have said at the beginning, mental health demand is actually 10% of our kind of work volume on a daily basis, so it's a huge part of our of our demand. And also there's a lot that we're doing kind of around training staff across the organisation as well. And I retain a kind of clinical practice, and I think some of my colleagues have joined today as well, who are kind of out and about every day, kind of seeing kind of patients. And I think something that we need to really do is really have these open and honest discussions here, and building on kind of Mike's point around kind of what, and around kind of, and Arden's point around things that have been happening. I think we really need to ask ourselves, why are things happening? Why do we not know? Why did we not know how many people were being detained under section 136? Why didn't we have that figure? It seems like it would be something that we could easily have kind of captured. Why wasn't things like the forms or our practice kind of updated over the years? And I think when we start to ask ourselves those questions, we can truly start to kind of unpick the real kind of issues that we face. And I think something that I observe, and especially at the moment, because we've all, COVID has impacted on all of our lives kind of personally and professionally as well. I think that we need to start to definitely think about this as a system level kind of issue, and something that I have seen, having come over from a mental health provider into the emergency services, is how kind of, I guess, territorial we can be sometimes. And during times when we're very busy, we kind of put the shutters down and we try to kind of manage our own little areas of kind of practice, whether that's the police or health. And I think it's really important that we start to kind of look at this, because we see that unfortunately the ambulance can sometimes be delayed getting to patients who've been detained under section 136, and then even before that decision is made, are we doing enough to prevent somebody deteriorating to the point that they need to be have their kind of liberties removed? And then also the experience once the detention has happened that Arden touched on around why are people going to the emergency department? And I think until we all start to unpick those questions and have these honest and sometimes maybe uncomfortable discussions, then hopefully we can truly start to drive some change on a kind of system wide level. And I think we all have a duty to do that, either as as clinicians, but also as members of the community and people that have a voice. So yeah, they're my kind of reflections.
Okay, thank you very much, Carly, and I'll come back to you to ask you, just for people have thrown around numbers like 80% of people at your paramedic joint car service sees do not end up in EDs do not end up in crisis places where they're not going to get the expert help. Can I just check, is that the kind of figure that you identify with?
Yeah, and I guess for me, that was obviously, we like to look at data and then we find maybe a positive or a negative, story in data, and we run with that. But for me and the team, we've never kind of focused on, how many of, ED journeys that we don't make with our patients, because completely sometimes a person may need to go to the emergency department. But so for me, it's about the quality. But yeah, one of the kind of byproducts of joining these two clinicians together has been that we've been able to significantly reduce trips up to the emergency department when we compare it to our business as usual, because we've got the kind of expertise of both kind of angles, and we do also monitor things like recontact rate, and so we can see what happens to kind of patients in the subsequent days after they've been maybe referred to a pathway in the community, for example. Yeah.
Well, thank you very much, Carly. I mean, one of the things that is often criticized about the health system, and it used to be criticized, is that the one number that was always publicized every single year was the 4-hour wait in ED. That figure almost became, for many people, the measure against which the health service was judged. Not everybody always, but it was the one that hit the headlines, and successive secretaries of state, it was probably the one figure they dreaded seeing. And I suppose my question to everybody in the panel is when we focus on one part of the system, like crisis, and all we focus on, the only numbers we publish for that are the numbers of people that come. How long did it take them to be seen? How long were they in that place? How quickly were they got out? And we're not asking any questions about who are the people. The availability of information that says it's 50% women, or it's 35% people from BME communities, or it's 70% of people who are already known to services. So what's the care plan? It's 80% of people are homeless. If we don't know the circumstances that are driving these crises, then will we ever be able to do any prevention? And I want to start by kind of asking Jim, because Jim, I know that you've looked at another element of this, which is about training. Do you want to tell us a bit about your focus?
Yeah, so for many years now, I've been heavily involved with a number of mental health charities. I have specialized in veterans' mental health and advocating on their behalf. And through that work, I now sit on a number of mental health groups, and we've been working on the mental health transformation team and digital programs, and also we were invited to talk about Section 136, and it was very interesting when we opened up the discussion to people about Section 136, how broad the topic was and how confusing it was, even for those people who are using it daily as a tool of their work. And I'll let you into a secret here. I'm poacher turned gamekeeper, because I now work for the LAS on the emergency ambulances. So I have a unique insight in that I have had experience, and I now treat patients who are in crisis, and I feel their pain massively when I'm there. And since being involved in this, every time I bump into a police officer at work, I ask them about Section 136, because I really want to know where the issue lies, or if there is an issue with it. And the thing that always comes back is within the process is they always think that it's the LAS's job to look after the patient, and the patient always thinks it's the Met Police's job to look after the patient, because the patient has been put under a Section 136. And there is that confusion of who actually leads it. And that's not in the sense of who actually performs the task. It's more a case of the fact that very, very often the police will have to call the London Ambulance Service to physically check the patient and clear them medically. So in terms of resources, you end up with a hell of a lot of resources on a single job. which all, whether it's the police or the clinicians, find very frustrating. But as well with the you know, obviously with the delay in timings that we have suffered in the past, that job can go from a very simple mental health job to, as you said, 6-7 hours of individually dealing with someone who is in mental health crisis. And that is a very tricky, very, you know, in my mind, a very specialized job. That should be mental health clinicians looking after someone in crisis for 6 or 7 hours. So there's that frustration in there as well. So we've been looking at, with a working group, trying to identify if there's any training needs that we can address so that it becomes a lot clearer for everyone involved of what the responsibilities are, but also on how to share those equally so that we get the best outcomes for the patient. And that ultimately is what we are trying to do, is to get the best outcomes, you know. And I've just been making notes as you were all talking, so I just use this to reflect as well, you know, the police being there. Every group I go to, there are a number of mental people who have had mental health issues who find the police uniform a trigger in itself. So it goes from being a simple crisis outside, it turns into a separate issue when the police arrive. And as I said about my own story, the whole anxiety around having the police there. Now, please don't think I'm knocking the police. I'm not at all. I'm just stating that feedback from patients is, you know, if an ambulance turns up with a paramedic, we quite often find the patient is a lot calmer and a lot more able to deal with us. The police in themselves, through no fault of their own, can actually end up escalating the situation because they're not aware that that patient can be triggered by, you know, by the uniform. And, you know, a lot of feedback as well is about actually the term section 136. Actually, the term 136 has become, in my opinion, and from the feedback I get through trying to deliver the training or trying to work on the training, is that 136 has become weaponized as a word. It is, you're going to be 136, or I did this, and I got 136. And if you talk to a lot of people, it is very often you find that they don't realize that it is section 136 of the Mental Health Act. It has become a term in itself, 136. And that term can strike fear in people's hearts. You know, don't do that, you're going to get 136, or, you know, the police turn up on 136. And I was speaking to a police officer the other day, and she said to me that she can honestly say she has taken more patients into custody under the section 136 Act than she has arrested, because it has become that much of a problem. And the biggest problem that we all have here is that as the units for mental health are reduced, as the amount of beds for mental health are reduced, it is at the same time that mental health rates are going up. So it has become the norm that people are taken into custody because that's designated as a safe place. But it is not ideal for mental health patients. Leaving mental health patients in A&E, you know, they have 2 or 3 rooms at most, and then once they're full, they're sat in with everyone else in A&E, and that's not ideal for someone with mental health crisis. So we're sort of meeting this, although we're talking about 136, there's this whole, as Carly so very eloquently put, there's a systemic issue there as well. You know, even if we found an effective way of dealing with these patients, where do we actually take them afterwards? Is there resources to do that? And I think the mental health cars have proved massively effective. And I was speaking to someone from Northwest Ambulance, and they did mention that their section 136s went down by about 80% when they adopted this plan over a 6-month pilot project. So we do know they work, but I think if we're going to talk about the subject, we need to develop that training with the police, with the LAS, but also we need to look at what we do with the patient and where we place them afterwards.
Thank you very, very much, Jim. You covered an amazing amount that I think we will definitely reflect on when we listen to the recording of this. Arden, you've got your hand up.
Sorry, I have. I was just picking up on a couple of things that Jim had said there, but also a question that's gone in the chat from Jen. talking about training and police and the fact they spent time on a ward. Again, in the spirit of the kind of openness of this forum, when we did our process mapping and when we got out to really understand the pathway in more detail, there was a few exercises that we did. One of which is all of my team have been on what's known as ride-alongs with police mental health teams. So we've gone sat in police cars and gone around and spoken to officers about how they feel about Section 136. But also we spoke with some kind of mid-tier management, and there was an inspector that we spoke to one day. I think he ran between kind of 60 or 70 police officers in a given shift, and he was very open. He said, "Well, if I get a mental health call, I send my most junior officers because they're going to be tied up for 6 hours, and that could be the whole shift." So he's like, I don't want to send a kind of rapid response car or a highly trained officer, seasoned officer, because they might be needed for something else, rather than being sat in A&E for 6 to 8 hours. So openly saying, no, we are sending our most junior officers to look at mental health instances, which was kind of quite surprising. I thought they'd be sending specially trained officers to deal with this, but he's just like, the constraints of my service are that I don't, and I send these people, which is, having then spoken to the officers, they find it quite distressing because they're trained to go and chase bad guys, and now they're not. They're talking to somebody who may or may not be able to communicate with them, may or may not have self-harmed themselves, whatever it is. So again, as Jim's saying, the training, having the right people responding to the right instances, and from my side, holding a mirror up to that in the first place and saying, well, look, this is bluntly what's happening. Is kind of where we sit. So yeah, that was just what I wanted to add to Jim.
Sorry, as well, Arden, that quite often we'll find that if the patient is uncooperative, that goes from 2 junior officers to 5 or 6 police officers on scene. And so, when you look at the resources used in one single Section 136, you can have a crew, an ambulance crew, 5 or 6 police officers, and then we move them into the hospital, and the resources they're then used in the hospital. So it is a massive issue on that front alone before we even discussing the individual needs of the patient.
So I suppose in today's world, where we're trying to think about what would help all our statutory services be sustainable post-COVID in this very economically challenged world, in a sense, what you're saying is, whatever else about the ethics likely to be a non-sustainable model going forward, we really do have to think differently. Mike, in the work that you're doing at national level, is there anything that we can draw on that work that could kind of just help us think more clearly about this whole detention issue? And we've picked on 136 as probably one of the most interesting ones to begin with.
I think there are 2 concerns that I'd express. The first is, and it's something that Arden was speaking about, which is that we often don't listen enough to the anecdotes. Most of the things that Arden has said about the findings that he's identified would be things that we will always have been talking about. We know this stuff. Why are we not convinced by the anecdotes? That's the question I've always had, going back to dissatisfaction about local street policing. The point that Jim just made, about the nature of street encounters. If a police officer is trying to arrest somebody under 136 on the streets, because of the antipathy built up over generations in parts of our communities, those incidents themselves are very highly sensitive and problematic incidents. So that's all about trust and confidence. It's about the history. It's about what's gone on before. So the first issue for me is, why do we not listen enough to anecdotes? There are anecdotes, and Jim indicated this, about ex-service veterans being homeless. We know that because it's anecdotal, and we see them. but we still require research and proof. We need to listen to those experiences. And the other thing I'd say is that whilst we rely on data and digitalization, we have to remember that part of the biggest motivation, the biggest driver for change is that humanity. It's about understanding what it feels like. Jim talked about, knowing what it feels like and bringing that to the table. That can drive action. So, in our attempt to sharpen our data and make sure it's accurate, let's not lose sight of the lived experience and the anecdotes.
Thank you, Mike. I suppose one of the reflections I often have in this, so say if we take something like the fire services, a couple of decades ago, most fire service responses were about intervention, because most fires are related in some way to domestic fires, road traffic accidents, other kind of natural disasters. And the fire service is set about looking at, well, who are we being called to? What are we being called to? Who are the people we're being called to? What might have, let's hear their views about what might have prevented it happen in the first place. And I think we've seen that enormous shift in fire service, as I say, from intervention, 90% interventions dealing with the problem, to actually a great focus, 80-90% of the work on prevention, trying to get safer systems in place, trying to understand who's vulnerable and who therefore needs a particular type of intervention, getting legislation changed, but also kind of getting systems changed. So taking those, as you rightly say, those insights, Mike and Jim and Adam and Carly, insights from people, and turning them into is this a problem that we could tackle one by one? So Carly, do you, expanding your service is something that I know a lot of people would be hugely supportive of, because it seems to work for people. People find it more compassionate, kind, humane. Other parts of the country do things a bit differently. They do street triage with police and paramedics. If you could wave a magic wand, is expanding your service something that you would see as being fundamentally very important in reducing detentions and 136?
No, I actually think it shouldn't get to the point necessarily that people call 999. It should be that having to get to the point where you have to, call either police or an ambulance service for your mental health crisis. We shouldn't really be getting to that point, and it's about what's happening kind of before that happens, and whether that's because our mental health is deteriorating, and are we linked into the correct kind of services or pathway, and then also around kind of social kind of issues that people face in the community. So yeah, obviously a solution would be, yes, have more mental health cars, but it doesn't fix the systemic kind of issues that we face in this country currently. Yeah.
Pardon, do you think that the insights that you're getting, or that your digitalization process is hopefully supporting both police forces and mental health staff to look at, well, who are the people? Because I think we know what some of the determinants of crises are: homelessness, loneliness, living alone without support, not feeling you're an excluded member of society, no access to education or apprenticeships or employment. But I don't know whether that's ever actually quantified in each local integrated care system area. Is that quantified? So instead of shouting and anecdotally saying, we know that we see a lot more homeless people, we see a lot more people on stable housing, we're actually able to say to directors of public health and local systems, these are the proportions of people we're seeing each year, and this is a fundamental problem. How can we work together to resolve that? And can we set any kind of ways of reviewing that regularly? Do you think that some of the digitalization pathways and the information that will come forward on the health side, as well as on the police side, is going to help us be a bit more concrete about turning the knowledge that people have into actual improvement initiatives?
That's my hope. That is absolutely my hope. And I think, to pick up on Mike's point, the anecdotes have always been there, and definitely should be listened to. I hope that we are able to kind of give those anecdotes more weight, by saying that this is not, because often the people sharing the anecdotes are the most passionate, and often the people that have to make the decisions are trying to make them on kind of cold hard facts. So if we can deliver some of those facts to bluntly and slightly freely, decisions are made on the back of PowerPoint presentations, and a chart in a PowerPoint presentation goes a lot further than a quote bubble in a PowerPoint presentation. And if we are able to say this percentage of people coming through services are homeless, or this is the background, it makes good on a PowerPoint presentation, it helps build business cases, and I hope that could be a kind of force for change. I'm afraid that what we found is the anecdotes are too easy to ignore or say, well, that's just your experience, or that's that. But then you need them. The best for me is to have the hard data within the colour provided by the right individuals. And I hope that's what we're getting out of this project, is we've been given a voice to some really quite passionate place of safety managers who've set up some brilliant local processes. And I have to say, as I think you know, Geraldine Eilish at the Maudsley Place of Safety has been just fantastic. And then Denisha in Camden, and Kahindi in Oxley's have just, they've really got a handle on their local police relationships, and they are you know, not senior people, but they get it, they understand it, they've been saying this stuff for years, and now we give them a spreadsheet and they go, look at this spreadsheet, and then other people can hear it a little bit higher up. So I hope that's what we're able to lend to it. Yes.
Terrific. Can I just say you've been the most absolutely amazing panel, because we've got heart and head the whole way through brought together, and kind of really open reflections. Could I just ask for one final comment from each of you? Just, you know, what's the one takeaway message you want people to have from your perspective, having been on this panel today? Jim?
I think for me, these forums are amazing, and I sit with lots of groups and we share experiences, and it's very easy to sit in these groups and be passionate about mental health and to talk about the issues and to talk about the things that are happening. And then you leave the groups and you go outside and nothing's changing in the world. You know, it's very easy to take snapshots of people that put mental health as a priority and putting the patient at the center of care and making the treatment relevant, making it effective, but you then have to fight the system to get it. And I think my takeaway is that everyone here has spoken amazingly. It's trying to share that passion and that motivation with people that can make the changes where it, you know, that's where it takes the time.
Thank you very much, Jim. Practical, proportionate, and passionate for people. Yep. Mike, finishing words?
Well, I found it really enlightening and very humbling to listen to some of the contributions. My takeaways are some of Jim's sentiments about the reality and about lived experience shaping the way we go forward. And the other takeaway, obviously, is Arden's points around the importance of data. You know, I often take some convincing, Arden, about the practicalities of researching into things that we already know. But I do take the point about it adding power to the arguments. And I guess the other thing I want to reflect on is a comment that was put in the chat by Lovelyn, which is about the impact on staff that work for us. Yeah. And Geraldine will confirm that I chair the committee for the board that looks at our staffing issues and the well-being of staff, particularly in relation to some of the things we talked about today, is high on our agenda. And we can't do this successfully without our staff and without supporting our staff too. So that's a point well made too. Thank you.
Okay, we've actually, believe it or not, run out of time for a finishing quote, but can I just get very quickly, Carly, what's your takeaway, your big takeaway?
I think we just need to keep talking and reflecting and having open discussions. Yeah.
Arden?
Get all the perspectives, I think, would be my takeaway, and that's what's been really good here.
Terrific. Well, thank you. You've been amazing. Thank you so much, panel. And thank you, audience. You've been really reflective and listening. And I'm so sorry we didn't get time to take all your questions. But in the second part of this topic series, please come back and listen. And we will perhaps make a bit more time for questions for you all. But thanks again, very, very much indeed. Take care. Have a good afternoon.
Thank you, everybody.
Bye.